Imagine handling a medical tool so incredibly fragile that, simply pushing a syringe too fast will completely destroy it.
Right.
But at the same time, it's so devastatingly potent that just a single rogue splash can permanently paralyze your eyes.
Yeah, it's wild.
It really is. Today, we are pulling our insights directly from the transcript of this phenomenal YouTube video. It's titled HCC 1475-25 Botox Injection, and it was uploaded by the channel Gautamukala S. Raju.
A really fascinating source.
Oh, absolutely. Our mission today is to explore the unexpected, highly delicate, and honestly crucial role of Botox, which is botulinum toxin, in advanced gastrointestinal endoscopy.
Which is not where most people think of Botox being used.
Exactly. For you listening, we are going to dive into how specialists deploy this neurotoxin deep inside the digestive tract to perform, literal life-changing interventions. And we'll look at why it requires such extreme precision, deep physiological understanding, and literal safety gear to pull off safely. Okay, let's unpack this.
It really serves as a perfect masterclass in clinical paradoxes, I think. We're going to examine the exact structural science of preparing this medication, the stringent safety protocols that literally take over the operating room, and the severe gastrointestinal conditions it treats.
Right.
Because analyzing Dr. Raju's breakdown completely reframes our understanding of a substance most people, relegate strictly to cosmetic dermatology.
Yeah, like wrinkle smoothing. But before discussing how Botox works inside the human body, we have to start with the vial itself, because the physical preparation of the medicine is shockingly fragile.
It's incredibly delicate.
Yeah. Before a scope even enters a patient, the team has to address the vial. According to the transcript, the Botox arrives as 100 units of this very fine whitish powder, sealed in a tiny vial.
Right, it's lyophilized powder.
And to activate it, the team has to reconstitute it using a 5cc syringe filled with sterile saline. But it has to contain absolutely zero preservatives.
Zero. And what's fascinating here is the underlying structural vulnerability of that active agent. We have to remember that botulinum toxin is a highly complex biological protein.
Okay.
It possesses a very specific, intricately folded tertiary structure. The source heavily emphasizes that the injection of that pure saline into the Botox vial must be executed with extreme slowness.
Right, so if you just push the plunger too fast, you completely ruin the medicine.
You do, because you create a violent, turbulent physical force in the fluid.
Just from the fluid hitting the powder.
Exactly. For these delicate protein structures, that mechanical shear stress is actually enough to unfold them.
Oh, wow.
Yeah, it renders them biologically inactive.
Yeah.
You are mechanically denaturing the therapeutic tool before it even touches the patient.
That is wild, which implies we aren't dealing with a robust chemical compound at all, but something highly susceptible to physical forces.
Precisely. Which is why the source is so adamant about this. The saline must be introduced gently down the side of the vial.
And the instructions get even more specific once the fluid is in there, right? You must gently roll the vial between your fingers to mix it.
Right.
You never, ever shake it. Knowing what we just established about shear stress, I have to assume shaking introduces aggressive, cavitation or air liquid interfaces that would just further denature those proteins?
It does, absolutely. Shaking creates these micro bubbles, and the surface tension at the edge of those bubbles exerts immense stress on the protein molecule.
So they just break apart?
Essentially, yeah.
Well,
they aggregate and lose their efficacy. By gently rolling it, you allow the powder to dissolve, organically into the saline matrix without introducing those destructive physical forces.
And that extreme care continues right up to the draw. Once it's reconstituted, the medical team has to aspirate the liquid back into that 5cc syringe, again at a remarkably slow pace.
Very slow.
Since the vial started with 100 units of Botox, doing the math, drawing back those 5cc yields a final concentration of 20 units per 1cc.
Exactly. And that highly specific ratio is the absolute bedrock for the geometric dosing they will use later in the procedure. This whole initial phase highlights a core truth about specialized interventional medicine.
Which is?
Efficacy isn't just about the pharmacological properties of the compound you inject. It is fundamentally governed by how you manipulate the physics of the drug before it ever crosses the sterile field.
That is so true, but you've just described a protein so structurally precarious that a fast squirt of saline obliterates it.
Right.
If you're listening to this, you'd logically assume the substance itself is highly unstable and probably relatively harmless if you spill it.
You would think so.
But the operating room protocols in the source dictate the exact opposite. Here's where it gets really interesting. Before any injection begins, everybody in the room has to put on protective eye gear.
Everyone. The endoscopists, the nurses, the assistants, and crucially, the patient themselves.
Yeah. Everyone is shielded, which is a bizarre visual, right? A GI doctor who is treating the stomach and esophagus suddenly requiring safety goggles like they're in a high school chemistry lab.
It paints quite a picture.
But knowing what botulinum toxin does halting muscle function, I have to assume a stray splash to the face would do something catastrophic to the extraocular muscles.
It absolutely would. The source notes that if the liquid accidentally enters the eye, it causes immediate diplopia.
Which is double vision, right?
Yes, double vision. And that localized paralysis tells us exactly how botulinum toxin operates at a synaptic level. It strictly interrupts the communication between peripheral nerves and muscles.
How does it do that?
Well, normally, nerve endings release a neurotransmitter called acetylcholine, which binds to the muscle and commands it to contract.
Okay, that makes sense.
But Botox acts as an absolute roadblock. It cleaves the specific proteins required to release that acetylcholine. The chemical messenger is just never deployed.
So the muscle is completely isolated from the nervous system.
Exactly. It receives no input, so it simply stops contracting and enters a state of flaccid paralysis.
Wow.
And human extraocular muscles, the ones that move your eyes, they are incredibly sensitive. They rely on constant micromillimeter adjustments to maintain binocular vision and keep your eyes aligned.
So if a microscopic amount of Botox hits those muscles, that precise alignment is instantly lost.
Instantly. This strict goggle mandate demonstrates how overwhelmingly potent this neurotoxin is when it hits the wrong physiological target.
So we've established this is a rogue biological agent that is both structurally fragile to handle yet potent enough to paralyze a doctor's eye from a single splash.
Yeah, quite the combination.
To justify bringing that level of risk into an operating room, the payoff for the patient has to be monumental. And that brings us to the main event, the actual target. A condition called achalasia, specifically in an elderly demographic.
Right. Achalasia represents a profound breakdown in esophageal motility.
Normally when you swallow, it triggers a coordinated neural relay switch. That relay temporarily cuts power to the lower esophageal sphincter.
That's the muscular valve right above the stomach.
Right. It relaxes and allows food to drop through. But with achalasia, that local nerve plexus is essentially fried. The muscle is receiving a continuous, relentless electrical signal to stay clenched shut.
It is a state of severe, unrelenting spasm.
Yeah.
The valve absolutely refuses to relax.
It's like a jammed door that won't let food into the stomach. The patient literally cannot swallow their food. It just backs up in the esophagus, causing regurgitation, severe pain, and over time, profound malnutrition and starvation.
It's a devastating condition. And the source specifically targets this Botox intervention at elderly patients who are not fit candidates for more aggressive therapies.
Why is that?
To understand the value of this injection, we have to look at the alternatives. The source mentions pneumatic balloon dilation or surgeries like a Heller myotomy and POEM.
POEM stands for peroral endoscopic myotomy, right?
Exactly. In a myotomy, a surgeon is physically cutting and severing the circular muscle fibers of the sphincter to permanently destroy its ability to clench.
Which is an incredibly effective physical fix, but an immense physiological trauma.
It really is.
If you have a frail 85-year-old patient with multiple comorbidities, putting them under deep general anesthesia and physically slicing their esophageal tissue carries a massive mortality risk.
Right. Their cardiovascular system simply might not survive the cure.
Which leaves them trapped in this terminal decline from starvation, unable to survive the definitive surgical fix.
And that is precisely where our fragile, perfectly calibrated vial of Botox becomes a vital tool. The endoscopist guides a flexible scope down to the spasming sphincter and deploys a tiny 23-gauge injection catheter.
And the coordination required in the suite at this moment is just phenomenal. The source details how this injection demands strict, loud verbal communication.
It's extremely regimented.
Yeah. The assistant holds that 5cc syringe we prepared earlier, and they don't just push the plunger, they inject in microscopic 0.5 milliliter increments.
Very slowly.
And as they do it, they loudly call out the dosage to the doctor. 0.5 ml injected, 10 units delivered. 1 milliliter injected, 20 units delivered.
It is a closed-loop communication protocol, identical to aviation or aerospace standards.
It sounds exactly like a tense spaceship launch sequence.
It really does. The endoscopist is focused entirely on the visual feed from the camera, manipulating the catheter needle into the exact depth of the muscularis propria.
While the assistant manages the fluid dynamics.
Exactly, announcing every single milestone so the physician knows the exact distribution of the payload.
And that precise acoustic feedback is mandatory because they are distributing the medication geometrically, right?
Yes. They typically inject it into 4 specific quadrants of the sphincter.
Visualize like a clock face.
Right. At 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. They deposit 20 units into each quadrant. Depending on the patient's specific anatomy, they might even expand that to 8 separate injection spots, utilizing maybe 10 to 15 units each time. They are strategically and symmetrically blanketing the entire circumference of the muscle with the neurotoxin.
And as that botulinum toxin diffuses into the muscle tissue, it executes that synaptic blockade we discussed earlier.
Yes.
It shuts down the hyperactive acetylcholine release. So the sphincter, which has been locked in this agonizing spasm by misfiring nerves, is suddenly chemically isolated.
And it finally relaxes. Visually, right there on the monitor, the endoscopist can watch that stubbornly tight lumen yield and open up.
The jammed door finally opened.
It does. And the clinical result is immediate. An elderly patient who has been suffocating on their own meals, aspirating fluids, and wasting away can wake up and successfully consume nutrients again.
That is amazing.
It is a profound restoration of esophageal patency, achieved not with a scalpel, but through highly synchronized teamwork and a few precisely placed drops of a paralyzed protein.
It is an elegant workaround for a deeply mechanical problem. But opening a chronically clenched sphincter in the esophagus isn't the only application.
No, it's not.
The source material expands the map, showing us other areas in the GI tract where targeted paralysis resolves localized ischemia or obstruction.
Because the gastrointestinal tract relies on highly pressurized, compartmentalized zones.
Right.
If you chemically alter the tone of one valve, you inevitably disrupt the pressures in the adjacent compartments. But as with all medical interventions, forcing these physiological doors open always comes with consequences.
Let's explore the other applications first before we tackle those systemic trade-offs. The source notes the use of Botox for gastroparesis, specifically related to pyloric spasm.
Right.
Targeting the pylorus makes physiological sense. If that gastric outlet valve is locked in spasm, gastric emptying halts entirely.
The stomach just can't empty.
Exactly. Injecting the pyloric sphincter relaxes it, allowing the stomach to finally empty its contents into the duodenum.
The source also highlights anal fissures, which present a really fascinating pathophysiological loop.
How so?
A fissure is a painful tear in the mucosal lining. The extreme pain from that tear triggers the internal anal sphincter to violently spasm.
And I assume that continuous muscle spasm severely restricts local capillary blood flow to the area.
It does. It creates a state of localized ischemia, starving the torn tissue of the oxygen and nutrients it needs to actually repair the tear.
Wow, so it's a self-perpetuating cycle of pain, spasm, and non-healing.
That is the exact mechanism. By injecting Botox directly into that hypertonic sphincter, the physician chemically breaks the cycle.
The muscle relaxes.
The muscle relaxes, the pain subsides, but most critically, the cessation of the spasm restores normal perfusion and blood flow to the ischemic tissue. The body is finally permitted to heal its own lesion.
It's like turning off the body's overreaction so the natural regenerative processes can come back online. The source also notes that historically, some specialists utilized it for spasms in the sphincter of Oddi, though Dr. Raju mentions that is largely falling out of modern practice.
Clinical algorithms constantly evolve as longitudinal data reveals long-term efficacy versus risk, which, transitions us perfectly into the complications associated with these procedures.
Yeah, so what does this all mean? We have this incredibly effective, minimally invasive procedure for our elderly achalasia patient, but the source explicitly details some very real physiological consequences.
It does.
Post-procedure, patients frequently experience transient chest pain. Knowing we just injected fluid directly into an active muscle layer, transient localized inflammation seems like an expected, manageable immune response.
It is. It's generally self-limiting and resolves quickly. But the secondary anatomical complications are much more profound.
Right. The source points out that a major chronic side effect is severe acid reflux and heartburn.
Because the lower esophageal sphincter, the barrier we just chemically paralyzed, is no longer tightly closed.
It cannot prevent acidic gastric contents from freely washing back up into the unprotected esophagus. Furthermore, the source warns that Botox injections lead to fibrosis,
Which is scarring within the muscle tissue itself.
and that makes any future surgery in that area very difficult, if not impossible. I have to push back here. We fix their ability to swallow, but give them heartburn and potential scar tissue.
I know it sounds intense.
We condemn them to severe chronic GERD and fundamentally alter their cellular architecture, filling their esophagus with scar tissue so no surgeon can ever operate on them. That seems like a devastating clinical trade-off.
If we connect this to the bigger picture, we are touching on the very soul of clinical triage. You are looking at the complications in a vacuum rather than measuring them against the pathology of the alternative.
Okay, walk me through the cellular mechanism of that fibrosis first, and then the clinical scale. Why does a chemical neurotoxin cause physical scar tissue?
When you repeatedly inject botulinum toxin, you are subjecting that muscle to prolonged periods of chemical denervation. Muscles require constant neural input to maintain their mass and structure.
So if they don't get it...
Without it, they undergo severe atrophy. As the functional muscle fibers shrink and die off due to lack of use, the body's fibroblasts move in and replace that void with dense, collagenous fibrotic tissue.
Oh, wow. You are literally replacing flexible muscle with rigid scar tissue.
Exactly.
Which explains why a surgeon attempting to cut through that tissue later would find it a complete nightmare. It's no longer organized muscle. It's a chaotic, dense web of collagen.
Precisely. The tissue planes are totally obliterated. But remember the specific patient profile the source established at the very beginning of this clinical pathway.
Right. The 85-year-old frail patient. The one who is already disqualified from surgery.
Yes. The risk of fibrosis perfectly justifies why this protocol is strictly reserved for patients who aren't viable surgical candidates in the first place.
I see.
If a robust 35-year-old presents with achalasia, an endoscopist will actively avoid Botox precisely because they do not want to induce fibrosis and burn the bridge to a definitive Heller myotomy.
They want to preserve that tissue architecture.
Exactly. But for a frail octogenarian with severe cardiopulmonary disease, surgery is already permanently off the table. The fibrosis is a clinically moot point.
And the chronic acid reflux.
It is the unavoidable mechanical cost of an open valve. But weigh that against starvation.
Yeah, that's fair.
For an elderly patient who is actively aspirating unswallowed food into their lungs and suffering severe caloric deficit, managing temporary or even chronic heartburn with daily proton pump inhibitors is a highly acceptable trade.
A wildly successful outcome, really.
Yes. In interventional medicine, you rarely achieve a perfect physiological state. You strategically trade a lethal problem for a manageable one.
That reframes the entire procedure. It is applied clinical pragmatism.
Well, we've covered an incredibly dense journey through this source material today.
We really have. We started with a vacuum-sealed vial containing a complex biological protein so fragile that we had to analyze the physics of sheer stress, learning that injecting saline too fast or shaking the vial would literally tear the tertiary structure of the medicine apart.
We examined the extreme localized potency of the neurotoxin, realizing that a single accidental splash necessitates strict ocular protection for the entire operating room to prevent the sudden paralysis of extraocular muscles.
And we stepped into the highly structured, acoustically precise environment of the endoscopy suite. We listened to the aerospace-style countdowns required to geometrically distribute 0.5 milliliter increments of Botox into a spasming sphincter,
Ultimately reversing localized ischemia in fissures and preventing terminal starvation in elderly achalasia patients.
Exactly. For you listening, the next time you hear the word Botox, you won't just envision a cosmetic luxury. You will know it's not just that, but a structurally fragile, mechanistically devastating neurotoxin that, when handled with profound clinical respect, helps our most vulnerable populations perform the fundamental human act of simply eating a meal.
And this raises an important final question for you to ponder as we look toward the future of pharmacology.
Okay.
Botulinum toxin is famously derived from bacteria. It operates as one of the most lethal presynaptic neurotoxins known to cellular biology.
Right.
Yet, through rigorous scientific mapping and exact procedural technique, we have elegantly harnessed its destructive capacity to heal the body. It compels you to wonder, what other deeply dangerous, biologically devastating toxins in nature might hold the exact molecular keys to treating our most complex medical conditions, just waiting for the right injection technique?
It's an incredible thought. Sometimes the most vital medical tools aren't the indestructible, rugged ones. Sometimes, to effectively navigate the complex physics of human biology, you need an exceptionally potent agent delivered with an incredibly delicate touch.